Welcome to the Vet Dental Show. I'm Brett Beckman. I'm a board-certified veterinary dentist, and we come to you every week on Wednesday to provide the veterinarian and the technician team some actionable things that you can use in your practice. And this episode is going to be a recorded episode that we've done in the past, not a podcast that we've recorded or not the Vet Dental Show, but actually some other information for you that we know you're going to enjoy. So sit back, enjoy, and we'll see you at the end of the podcast. Courtney has a good question. In case 10, if you have an owner that wants to pursue root canal, how long can the owner wait to be seen by a specialist? Really is such that most of the time when we see that there is a fractured tooth, it's not, the owner doesn't see it, it's recognized in practice. And if it is recognized by the owner, unless they see it happen, they're probably not going to recognize it in most instances. It's usually going to be picked up in a dentistry procedure on an exam at your office. Most of the time, we don't know when it happened. And most of the time, owners will come in and they'll say, and we had multiple cases this week that was exactly this. Most of the time, what actually happens, the owner comes in and he says, yeah, he fractured this tooth a month ago or 6 weeks ago, and we do the x-rays, and that tooth has been fractured since that 6-year-old dog has been 10 months of age. So and we can tell because of the root canal size. So it's not something that the owners are going to know unless they are there, they see the bleeding, the dog bites down and they scream on a hard chew toy or something and the owners detect it. So to answer your question, you're probably not going to know when that happened. So if you do know when it happens, and there was another question about this, about you doing vital pulpotomies on these that are fresh fractures within 24 hours, and I'll address that as well. But if we do catch those within 24 hours, some of our colleagues recommend that we still do a root canal. And I think the majority of colleagues recommend we still do a root canal because we don't know the extent of the contamination of that canal. And also Brooke Nemec did a study where he did vital pulp therapy on teeth that needed crown reduction under sterile circumstances. And there was a lot of those that did not play out to be vital down the road. So even under sterile circumstances, that procedure has not proven to be one that we usually do. Under the scrutiny of the specialist, it could be tried, and we might do that if it was something that happened immediately, but we just don't see them immediately, especially because we're only in Atlanta once a month and we're only in Orlando once a month. If you know when it happens, the best thing to do is analgesics, maybe a short course of a couple days of an antibiotic, amoxicillin, cephalexin, something like that, to handle maybe any surface contamination where you can help the pulp out a little bit, but NSAIDs until they can get in. And dogs are not generally going to show that they're uncomfortable, even though you can bet they are with that pulp exposure, especially in a young dog where it's a big piece of pulp. But we want to get them in, Courtney, in response to your question, as soon as we can, but it's almost never anything urgent unless we have known immediate pulp exposure that they know happened right then. So hope that answers your question. So Stephanie, just a general question I encountered throughout all the cases. As a general rule, when would you suture gum and when would you not suture gum? How about ones with tooth root abscesses? Sometimes don't close, not sure if that's right or wrong, but worry about fistulas forming and gum not healing after extractions. Let's address the last part of that question first. When we have a tooth root abscess, that's really not a true abscess. That's where the byproducts of pulp necrosis and or bacteria have destroyed the bone. We have replacement with granulation tissue. We do not have a true abscess. All of that gets to the point where it breaks through the bone and then it affects the tissue. when it affects the tissue, that's when it becomes purulent. Not until then. We have an unusual condition called a phoenix abscess in humans where there is an actual abscess, but those are extremely painful in humans. They are I think they're actually rare. I recall that they're not even very uncommon. I think they're rare. So we just don't see a true abscess in our patients. But the suborbital fistula, to go back to the correct terminology, the suborbital fistula is eliminated once the tooth is extracted, because all the infection that's in that tooth root, or all the inflammation that's in the tooth root and the bone, are removed when the tooth is extracted. And we will go in from the tooth side. We'll use our periosteal elevator to curette up in that defect and remove any debris that we can from the tooth side intraorally. We'll also go in, shave that area, clean it up, and clean it up with lavage of chlorhexidine in the actual cutaneous defect as well. We don't put those patients on antibiotics unless there is an extension of osteomyelitis that we see that we can't treat that's extensive. Good question. Now, going on to your second question, we do not, the only time that we really don't suture is when we are doing extractions of single-rooted teeth, or in some cases premolars of single-rooted teeth that are small that we've sectioned and we can extract without a flap. And those would be fractures. If they have periodontal disease, we really need to get up in there and clean out the defect. That may not require a huge flap in, say, the case of a second maxillary premolar, where you've got a two-rooted tooth and you've got, say, 50% bone gone. You could do a small flap just using your periosteal elevator to separate, the attached gingiva from the bone, and then section and remove as two individual tooth roots, and then go in there and clean with your diamond football burr, and then close those with sutures after those have been cleaned. The other instance that we would not now again, if they're not perio and you're extracting that, and you can extract those as simple extractions, and you don't have inflamed gingiva, you don't have tissue in there, you could extract both of those maxillary tooth roots without a flap. And in some cases, because that maxillary bone is a lot more cancellous than the cortical bone in the mandible, making those mandibular canine extractions difficult, and I generally don't do those unless I do a flap to take bone away. That would be the only case that you do that with a fracture without periodontal disease, is that first or second maxillary premolar. You get back to that third premolar, and there's a lot of maxillary bone that is thick, especially around the distal root. So mainly that's reserved for incisors, where we do get a lot of fractures. We get a lot of fractured incisors that don't have perio. And with those, we want to use our simple extraction technique without a flap that will allow us to elevate those, and then we just leave a blood clot there. We don't suture those extraction sites if the gingiva looks good, if it's just a fracture and there's no perio. So Lee, uncomplicated crown root fractures like the maxillary P4 slab fractures get to stay in. She's asking, does the fragment stay in? She's been taking wonder about perio. You always want to remove those. And most of the time when there is a slab, not always, but most of the time when there is a slab, there's usually a perio component that's going to be there then and possibly going forward. And if it progresses apically up the tooth root and it's a complicated crown fracture, even though the tooth root would let us do a root canal, we would not do a root canal on those teeth that are compromised. Some of those slabs go all the way up, half or more up the root, and those are not going to be manageable periodontal-wise going forward. So if there's any question, we use our periodontal probe and we can feel where that slab has gone up a lot of times. Sometimes we'll try to do a little flap and look up under there and see before we make that decision, but a lot of those are just way too severe. And you can look at that slab once you take it out, and you can place it back where it was on top of the marginal gingiva to see how far that's gone up if the slab is still there. Many times it's not. Many times the fracture's there and the slab has worked its way off. But if the slab's there, you can tell how far that goes up and make a decision whether that might even be worth referring for a root canal. If it's gone way up, it's not going to be a candidate. But yes, you want to take those out. If it's uncomplicated and you want this dentin to be, this would be where you'd have a dentin chalk trail in all likelihood. This probably would not be healed dentin underneath here. This is probably all exposed as well. And so you would want to be able to use a bonding agent after you clean that out and restore it. So that's a specialty procedure. Unless you've had an advanced course in restorations, you would not want to approach that. If I had that tooth and it was an uncomplicated crown fracture and it was that much involved, I would also put a crown on that tooth. Way too much exposure to expect that to last with a restoration, especially on that tooth. Hopefully that approaches that for you fairly well. Thanks for listening. I really hope you love that episode of the Vet Dental Show. Again, if you're a veterinarian and you want to be the best in dentistry and general practice that you can be, we've got something special for you at ivdi.org to be part of our class of 2024, one of 48 veterinarians that we have to make sure that you're in that group and make sure that you're off to the races as far as building your skills and your dentistry program in your hospital.